well, it's good to see a little bit of traffic going on here, although it's still not full force. Today is the day people are going back to work, kind of semi-officially, because here in Massachusetts, the authorization to go back to work has been put into phases, and we're still seeing emergency patients, but emergent care or things that are going to cause issues can be seen as well. So while not all dentists are back to work, many are to treat most of the dental disease being emergent. People are back to work to do that. So today I'm going to head back to work as usual, see a few patients, but I wanted to do at the end of the day today for you is to share with you some of the new CDC guidelines for dental practices, which I think is important for all of you here in the US, as well as many of our international viewers, in terms of what to do. So let's get back to work. All right, today's over. It was a short day, just a half a day. Just only 3 emergencies today. These patient and 1 cancellation too. And so anyway, just a short half a day here, and just heading back home now. I figured I'll quickly tell you these patients that I saw. Nothing really special, but just the first patient was a maxillary second molar actually, that had a problem with the sinus. The patient was complaining of sinusitis and so on for a long time. It turned out that the tooth was actually, the problem was odontogenic, and it was coming from the second molar. This guy's going the wrong way. That guy's going the wrong way on a one-way street, but whatever. The second molar ended up being the source of the problem that this patient had, and so we just did a root canal on it. Obviously, a 3D image was showing that we have 4 canals with the mesobuccal joining, and given the size of the infection in these cases, we have an emergency. We do schedule long visits nowadays, so we have plenty of time for disinfection and getting the teeth cleaned up. I did go to a size 4006 in the paddle root, and then the 2506 on the buccal roots, but I did use the 3D file at the very end in all the canals, along with the ultrasonics, to make sure that it's fully cleaned out and the biofilm has been removed, because that's super important. Now, otherwise, in cases like this, you probably want to do them on 2 visits with calcium hydroxide, but I do everything that I have enough time to clean out adequately in a single visit. There's motorcycle attack. They know it's a Harley. Anyway, the second patient was also referred for a second molar, mandibular second molar. But anytime you see a tooth with a recent crown and the patient's having signs of irreversible pulpitis, it is most likely from the recent crown and not the other teeth. So once we did a full testing on this particular tooth, it turned out that it was actually the first molar that was the source of the problem and not the second molar. And for you guys endodontists or endo residents out there watching this, remember not to ever trust, the referring sources for the number of teeth that they write down. You need to do all your diagnosis yourself, because you're ultimately responsible for that final treatment. If you just do the root canal that you've been asked to do, and it turns out to be the wrong tooth, you still are responsible for it. So anyway, this one was the first molar. And I found some leakage inside the crown as well, so we did the root canal, and instead of putting the BC liner, which I always do, in this particular tooth I ended up just putting in Teflon and Cavit, just in case they decide, so they can check when they go back in there the leakage that's going on underneath the crown, maybe decide to replace the crown on this one. And then the last patient was actually a young patient, it was a 19-year-old, who was told he also needs root canal therapy on tooth number 15, the maxillary second molar, and they had started removal of the deep decay that was going into the pulp, and then he was told he needs a root canal, and then he was referred by basically putting just Cavit in the access opening that they had tried to make after caries removal. And what I did is I checked out the level, I did the pulp testing and so on. It turns out that the patient had borderline irreversible pulpitis. So in borderline irreversible pulpitis, what I oftentimes decide to do, especially in a young patient, instead of doing the root canal therapy on a 19-year-old where you're hoping to, avoid the crown and so on afterwards, what we decided to do is just to do vital pulp therapy as a first measure here. So what I did is I just removed all the Cavit, cleaned out all the decay. There was an area with very close to pulpal exposure, as I could have seen previously on the CT as well. But we did not get at least any bleeding exposure. So what I did is I just placed a layer of BC sealer, high flow right against that area, so the calcium hydroxide, and then on top of that I put on the BC liner. Now what I did also was to etch the enamel ahead of time so that you can get a little bit of a better kind of a bond right there, and you can see that at the final shape it looks pretty nice and clean. Anyway, so these were these 3 cases that quickly were done. Hopefully are going to avoid a root canal on this one patient, on this young patient, and if needed then we'll obviously do the root canal, but I have a feeling that we might probably avoid it. We'll see. Anyway, the reason I want to talk to you now is to just kind of show you the CDC requirement that has come out. So let's go inside where it's a little bit quieter, where we can get through this document together and find out what is it that we need to do for our patients in dental offices. All right, let's go inside. Okay. Alrighty, well, all right, so let's get to work here. Whew. All right, get rid of this. Well, let's take a quick look at this paper. Alrighty, so let's take a quick look at this little paper by the CDC. That's coronavirus disease. Here we have 2019 COVID-19 guidance for dental settings. So this was released recently, just a few weeks ago, a couple of weeks ago, by the CDC as interim guidance, or rather guidance for dental settings of interim infection prevention and control guidance for dental settings during the COVID-19 responses. The key points here are that dental settings have a unique characteristics that warrant specific infection control considerations. No kidding. Prioritize the most critical dental services and provide care in the way it minimizes harm to patients for delaying care and harm to personnel for potential exposure to COVID-19. All right, fair enough. Although we have to get back to work, and it can't always continue to be that we're only providing necessary treat emergency patients. Now, proactively communicate to both personnel and patients the need for them to stay at home if sick. That is a really key point. We always have to make sure that every patient and also personnel now knows that if they are having any kind of symptoms, they should stay home. This is something that we weren't really doing before. If somebody had an appointment for a large chunk of time and they would call in and say, well, I am a little bit sick, I do know many dentists who would say, well, you know, they still can come in. That is no longer something you should be doing. Any patient that has any symptoms, you just have to make that cancellation. Hopefully they will let you know in advance enough that you can refill that appointment time. Now, know the steps to take if a patient with COVID-19 symptoms enters your facility. Clearly, if somebody has COVID-19, they enter your facility, if they have a fever, that you should really send them to their physician, and so that they can have follow-ups and make sure they do proper testing and that they can find out whether they do have the disease or not, or if it's not just some type of a fever that's unrelated. Obviously, people who have fever could have fever for many different reasons, including dental infection. So you don't want to necessarily send somebody who has large swelling and some type of a systemic signs of infection due to an odontogenic infection necessarily home. Usually here the telltale sign of a fever is about 100.3 degrees Fahrenheit. So this was updated on May 19th, 2020, and complements the following CDC guideline documents: the interim infection control that was released a little bit earlier, and then the framework for healthcare system providing non-COVID-19 clinical care. So this will take you to another page on the CDC website, the framework for healthcare system providing non-COVID-19 clinical care, with the purpose and the background and all bunch of explanations here for what you need to do. This is a little bit earlier, so it talks about the potential for patient harm and a whole bunch of different information here, and it has a couple of references. But this is not what we're talking about. This is the newer one. The summary of recent changes or recommendations are provided for resuming non-emergency dental care during COVID-19 pandemic. This is talking about going back and doing maybe hygiene work and periodontal work and things that are not necessarily that urgent or emerging.
as rapidly. And then new information is included regarding facility and equipment considerations, sterilization and disinfection, and consideration for the use of test-based strategies to inform patient care. And then expanded recommendations for provision of dental care to both patients with COVID-19 and patients without COVID-19. Now, in order to provide dental care to patients with COVID-19, clearly that has to be something that's very much of an emergency and that it cannot be delayed. And for probably 99% of dental offices, that's not something you want to do. You probably want to have one or two facilities in the whole city where this is provided, and that requires a far different level of infection control and negative pressure rooms and things like that the average dental setting has available. Now, but patients with confirmed COVID-19 cases are cases that are also primarily symptomatic and they're coughing, so the aerosol control is a far different level than patients that don't have confirmed COVID-19, that may have COVID-19, but clearly are asymptomatic or pre-symptomatic. Those are all kind of different provisions. Remember that there might be some viral particles in the saliva of patients that are pre-symptomatic or asymptomatic. Well, we do know that there are some viral particles in those patients, but the mode of transmission in those types of patients through regular aerosol with dental disease or dental treatment has not been clearly established. Most of the recommendations here in this paper are probably things that would make sense by proxy. There has not been a single case at the point of recording of this video that has been shown to be a direct transmission from a patient to a dentist or vice versa in patients that are asymptomatic, that are not actively coughing and so on. Well, actually in patients across the board, there hasn't been a single case. So that's important to kind of keep that in mind. And as long as we can avoid seeing patients that have active coughing, sneezing, or all kinds of different natural ways of sending the aerosol around, then what we're dealing with necessarily is just potential viral particles in the patient's breath, as well as potential aerosol that is created through the work that we do on the patients using a dental handpiece or piezoelectric ultrasonics and things like that. And those, in my opinion, can be controlled adequately with universal precautions and the wear of shields and face masks, whether they're respirators or type 3 masks. Again, none of these have been shown to cause a problem. So here on the background, what they're talking about is that we know that transmission is taught through spread primarily through respiratory droplets. When an infected person coughs, sneezes, or talks, airborne transmission from person to person over long distances is unlikely, however. So this is a question of proximity and patients that are coughing or sneezing and then or talking vigorously, which means that they are spreading those droplets. On the other hand, they're also kind of confessing that it's a new disease and they're still learning a lot about it, and the spread and severity of the illness that it causes is going to be shown over time. Of course, this thing persists in aerosol for hours, also on some surfaces for days under laboratory conditions. But whether this really means the laboratory conditions, remember, are looking at viral particles and RNA. They're not necessarily seeing whether you have actual live virus in every single case of these cases, but it's potentially possible. The other thing that we need to keep in mind is also the quantity of the virus. It's not as if you get one single virus into your body that you're going to necessarily catch the disease, unless you're very unlucky. And but otherwise, it always requires a high enough dose of the virus so that you're consuming a large dose, and therefore you are going to be susceptible to catching it, because it would supersede your natural and innate ability to get rid of the virus through your mucous membranes and just the innate ability that our body and respiratory surfaces have to get rid of infections. So you do need to have a large enough dose. So here in the risk portion, it's pretty clear that it says the practice requires the use of some water syringes, scalers, and ultrasonics and handpieces, and that causes a visible spray that contain particles, droplets of water and saliva, blood, microorganisms, and the debris. And surgical masks can protect mucous membranes of the mouth and nose from these droplets, but do not provide complete protection against airborne infectious agents. All right, fair enough. But also it says there are currently no data available to assess the risk of to transmission during dental practice. And to date in the United States, clusters of healthcare personnel who have tested positive have been identified in hospital settings and long-term care facilities, but no clusters have yet been reported in dental settings among dental healthcare providers. And that's a really key point, that all of these recommendations have been put forth in the absence of any evidence of transmission here. So people at the CDC are trying to be cautious, so they're recommending above and beyond the normal standards that they previously recommended with the HIV and universal settings, which were certainly designed to help deal with patients that had tuberculosis, AIDS patients that had tuberculosis, and all kinds of other respiratory diseases. So this is, again, above and beyond that, and probably it requires a little editorial. This is one of the reasons why I've been, and it's probably politically incorrect to say so, but I've been disgruntled with the ADA, American Dental Association, for abdicating the leadership role of telling dentists and making the recommendations themselves, and allowing a non-dentist entity, a non-dental entity such as CDC, to come in and take over and give leadership by telling us what we need to do, which means that you end up having engineers and people that are non-dentists at the CDC try to make recommendations based on proxy, based on not fully understanding the limitations and the difficulties and the things that we go through on daily clinical practice. So this is a gripe I have with the ADA that I'm willing to share right here on the record with you guys all, because I'm sure many other dentists out there are feeling the same way. And if you do, write it down below here. Anyway. So the urgency of the procedure's decision based on clinical judgment and should be made on a case-by-case basis. See American Dental what constitutes a dental emergency. So this is just passed for dental emergencies. Today we're dealing with just going back to work and treating all patients. But still, the clinical judgment should be done and made by the operator. Everybody, all the dentists have been adequately trained in infection control, and we all have that training. So there should have been, and that's what I was talking about with the ADA type of taking the leadership role and not making this a CDC issue, which creates all kinds of legal ramifications. We need to still rely on the clinical judgment of the operator. Universal precautions with the use of shield and masks and coverings still remains the same as it always was. Here, we're talking a little bit more, in addition to that, a couple of different things in terms of contaminated air and so on. So here are the recommendations to go back to the original framework healthcare reference recommendation that they originally had with some key considerations, as you can see here in this link, which was really, nothing specific that was far above and beyond universal precautions, I would probably say. And then it also says that this is an ongoing situation, you need to consult your state and local healthcare departments on an ongoing basis as more information due to this new disease has been found and shared. So you need to monitor these trends, and then other recommendations will be made. Regardless of the degree of community spread, continue to practice universal source control and actively screen for fever and symptoms of COVID-19. That's key. That remains the same as soon as patients walk into your office. You need to check their temperature. You need to check and log the temperature of all the staff and yourself as the doctor on a daily basis and keep track of those things. Any patient or staff member that is feeling sick should cancel their appointment. Staff members should not come to the office. So that means that you need to have better temporary staffing solutions for yourself, and creating, and I've seen this among some endodontists, that they have 2 separate shifts and 2 separate set of staffs on different days, and that allows them to piggyback if needed and change shifts if some group is potentially sick or one group is sick. That just allows you to have that backup system. So it says here, if community transmission is minimal, you still should be providing patients without suspected COVID-19 cases by adhering to these standard precautions. However, the patients may be able to spread the virus while pre-symptomatic or asymptomatic. That's what I was talking about, so you may not know that. So it's recommended that you practice under these below recommendations. In terms of the management, Contact all patients prior to the dental treatment. That's a key thing. And telephone screening is an important thing. You could do this online through many forms that they can fill out and sign. And telephone triage, as I was mentioning, of all patients is necessary. Request that patients limit the number of visitors accompanying the patient to the dental appointment, so you don't have many people come in and accompany with other friends and family members. And that is a little bit of a challenge because, as we know, some patients are very anxious and they need to have that kind of accompaniment. To the extent possible, you need to limit that and make sure you have adequate physical distancing between people. If they need to come to the operatory, they do need to wear masks and shields just like you. So this is what I do, as I mentioned before. In my office, everybody's wearing masks and shields. So if they have an accompaniment, the accompanying family member should also wear masks and shields, and then come if they need to come to the operatory or to hold hands or whatever. That's possible as long as they're protected. And here they're saying that they should be also patients should be wearing face covering when entering the facility and will undergo fever and screening tests. So essentially what we talked about. My office, they wear the masks and shield at all time. The only time they remove the shield or the mask is when I'm actually working on them, and they would be wearing safety glasses at that time. And as soon as I'm done with the work, they would put the mask back on as they leave the office and check out. So of course, this means that you need to make sure that you have adequate PPE available and that they are taking on and off their masks adequately. We do remove their mask, and we actually autoclave the material that we give them so that we can keep them and distribute between 2 or 3 different patients before we actually throw them out. By autoclaving them, you're obviously able to give sterile gowns and masks and everything to your patients. So in terms of facility considerations, you want to post all these visual alerts for patients to be able to read in terms of signs and posters, and then it's also important to have a strategic plan in your office. Just as a side note for yourself, in case someone in the office gets exposed, you need to know what you're going to do. What is it that who's going to take over, who's going to the chores from a dental clinical perspective, as well as the staff, assistants, front desk managers, and things like that. Because don't forget, chances are very, very low, if non-existent at all so far, that anyone in your office is going to get sick at the office. But don't forget, they will leave the office from 9 to 5. At 5 o'clock, they're going to go, and then along the way, they may not have adequate PPE when they're out there, and they might get sick. So what are you going to do with that? The key here is that from what people have seen, and many of my friends here at Harvard Medical School and at the hospitals, local hospitals, the physicians have been telling me that the staff that are getting sick are not actually getting sick from COVID patients at the hospital. They're all getting sick from outside, and then they're kind of that's where they're getting sick. So that's an important thing to keep in mind. You need to have a strategic plan to deal with such problems. Remove any kind of toys and magazines or other frequently touched objects by patients, so they're not sharing anything. You want your patients to come in and sit down and not really touch anything. One of the things we do, as I mentioned, when we give them PPE, patients, the moment they come in, they are wearing gloves. So that really helps in terms of reducing cross-contamination, because by wearing gloves, they're also not touching their faces as much because they're reminded of that. In terms of the equipment considerations, let's see here, you're talking about the dental unit water lines. That's a key thing. You always have to test your water quality to assure that you are kind of meeting the standards of the safe drinking water that are established by the EPA. That should be less than 500 CFU per milliliter. And prior to expanding dental care practices, this is something you should have done, COVID or no COVID. We do have closed water systems, and we're using distilled water, and then we're treating our lines constantly using different kinds of treatment materials to make sure we don't form any kind of biofilm on the water lines. Those are all important practices you need to do, using iodine and different types of disinfectants. That could be done through your suppliers on a routine basis for a charge, and that's very important to do, especially in practices such as endodontics, where it's all about infection control. You have to make sure that any kind of solutions you're using in a patient's mouth are not only disinfecting, but also disinfected completely, so that they're not causing any additional harm. So here you can confer with your manufacturer regarding their recommendations for these water lines anyway. So autoclave and instrumentation cleaning equipment, obviously you're still doing the same kind of a autoclaving of all the products and everything that you have between patients, your handpieces, all your different instruments and tools. Clearly, to the extent that's possible, we always go with disposable materials, but at the same time, we're trying to be green, so you don't want to use too many disposables that could be re-sterilized and autoclaved, but you need to therefore have a robust autoclave system, and you need to spore test your autoclaves on weekly basis to make sure that the autoclave is actually performing at the highest standard. That's an important thing. You could use biological indicators with matching control. That's a really important thing. And then for your air compressor, vacuum, suction lines, and radiography equipment, do to the extent possible, follow the manufacturer's instructions. All the surfaces still should be obviously cleaned between patients very well. So on the administrative control and work practices here, should limit clinical care to one patient at a time whenever possible. It would be ideal that if you work only on a single patient at any point in time. That may be difficult in some situations. Set up your operatories so that that only the clean or sterile supplies and instruments needed for the dental procedure are readily accessible. So keep that clean and dirty zones. Make sure you stick to that. Those are all common sense things. Here it says avoid aerosol generating procedures whenever possible. Avoid the use of the dental handpiece and air water syringes. Use of ultrasonic scales is not recommended. This is what you get when you have engineers giving you recommendations. What the hell is this all about? Avoid aerosol generating procedures whenever possible. Yeah, it's like it's by choice that we're using a drill or an ultrasonic. You have to use these in dental procedures, CDC. What the hell are you talking about here? So you do need to use these. The question here that comes up now is how can you avoid contaminated aerosol production? And to that, it goes back to my talk, to the little rant I had yesterday when we were talking in terms of use the rubber dam. That is what's going to help alleviate and reduce the contaminated aerosol, because there's two different types of aerosol. The microbes that are mixed with your handpiece, water, and saliva in the absence of a rubber dam are a whole different type of an aerosol than when you have a rubber dam and the handpiece water is hitting a tooth that is not containing large volume of virus in the saliva. So that's where the use of the rubber dam is so key. You have to really start to expand the use of the rubber dam in every aspect of dentistry. You can even do, I'll probably do more video tutorials on this aspect of dentistry, how to use a rubber dam to make a crown prep. And you'll soon see that by using that, and then your patients will become accepting of it. And the reason I say that is because as an endodontist, every single case that I have done in my career, of the 25,000 cases that I've done, has been done under a rubber dam. And to the general dentists who say patients complain about the rubber dam, I can always say, well, they don't seem to complain to me, because every time I'm doing a root canal, they do accept the fact that they have to have the rubber dam on for doing root canal therapy. So all they have to accept now is that they have to have it on for almost every dental procedure. And that's very much doable as long as everybody is in on it and everybody understands the use of the rubber dam is mandatory and should be done for every dental procedure. Then we're all going to be accepting. You can't not use a rubber dam, because today we have COVID-19. Tomorrow we'll have another disease that is going to also be found in saliva. So we need to make sure that we limit our exposure by using the rubber dam at all time. It says that if you do need aerosol generating procedures, then four-handed dentistry, high evacuation suction, and dental dams to minimize the drop in aerosol is needed. So I've seen some people use these large external suctions. That could be helpful. You could use a suction in this area. There will be new means, and working on something as well to help you guys help control the aerosol that's a little bit less obtrusive to the clinical care. So hopefully I'll get to talk to you about that soon as well. But in the meantime, make sure that you are using the rubber dam and you're using four-handed dentistry with suction nearby to help reduce the potential aerosol. Procedural mouth rinses, that's something that you see a lot of people doing, using, and look at this, there's really no published evidence that whether it's really effective or not, as everybody's using their own little formula with hydrogen peroxide, hypochlorous acid, all kinds of things that are people that are well-meaning, that are overthinking these things, and are coming up with all of these extra steps. Now, in the meantime, until the science is showing us whether it's helpful or not, you make the argument that it doesn't hurt to use it. And to that extent, yes, maybe you can use a low concentration of hydrogen peroxide or hypochlorous acid for rinsing or iodine rinses to help reduce the load of of the virus in the saliva if you're working in short periods of time. That's up to you. Engineering controls, here's where the engineers take over, and we're going to make all kinds of crazy recommendations here by your ventilation system, whether you should have a HEPA filter in there or not. The key here is to make sure that you have a recirculation of the air wherever you're working. They did not have any of this HEPA filter stuff and HVAC stuff in the operatories, and the study that I read from Wuhan that was shared with us with the dean of the Wuhan University School of Dental Medicine, where they had 2,000 cases that have been seen since their shutdown by 250 different practitioners, and they had found zero exposure or zero kind of a transmission of the virus to the healthcare workers. All they had kind of open windows, and they allowed the air to circulate. And that's something we can do certainly during the summer. That would be easy to do, to open the airway. But otherwise, you can invest into one of these air filtration systems. There is even simpler and less expensive ways to do this. Maybe I'll make a video of a less expensive method of making a type of a filter in your office that you can use for just recirculating the air. Because remember, the whole point here is to have the air that is present recirculated. One thing that they also kind of make a recommendation here in this paper is the fact that between patients, it's a good idea to let the air settle by waiting 15 minutes between each patient. This is, again, another one of those recommendations done by non-dentists who doesn't seem to understand what is going on. The waiting 15 minutes between patients just for the air to settle so that you reduce the aerosol makes no sense, because that's not a standard that we are requiring from, barbers or hairdressers or restaurants to do. In a dental office, you could make the argument that 15 minutes from the time that you're using a high aerosol producing procedure, such as the use of a handpiece, may make sense. So that after you've done your handpiece work, then again, that would be different if you're using a rubber dam than not using a rubber dam, but you may want to wait a little bit before the next patient comes in. Either way, we've found that you do need a good 10 minutes at least to clean and disinfect the room between patients. But sometimes you could work that out by moving patients and then into a next operatory, get started, and while the other operatory is being sterilized and cleaned and disinfected. Anyway, this goes on, but I don't think there is really that much. They're talking about the open dental floor plans and what you need to do with having at least 6 feet of space between patients, patient chairs and so on, which kind of makes sense. I think most offices do at least have a 6-foot distance between dental chairs. Again, easy to clean floor to ceiling barriers will enhance effectiveness of portable HEPA filter systems. Again, additional recommendations. Anyway, I'm not going to go into the hygiene part because as endodontists, we're not going to talk about that. Use of the personal protective gear, PPE, what is necessary. These are all things that you can read. Whether you do need to use a N95 mask for everything, that's another one of those kind of debates that hasn't yet been fully proven. I've looked at some meta-analysis studies on the difference in terms of catching the flu using N95 among a bunch of physicians. This is like real world kind of articles, not these types of proxy articles where they talk about the size of the filter, but rather, well, does it really make a difference substantially and clinically? Do physicians who are using N95 catch less influenza virus during a flu season than physicians who are using just using level 3 masks? And based on some of the studies that I have read, there is no significant difference. Much like many of the articles you see coded in endodontics, much of this stuff is now being coded is based on proxy benchtop studies rather than real world studies that show actual transmission differences. And so we're left by having to follow recommendations that are not necessarily based on clinical practical value, but rather just in case, to be on the safe side, let's be all safe, things that add a lot of cost and a lot of burden to the practice, but we still have to do. So my hope is that while the CDC recommendations seem to go a little bit farther than the universal precautions at the present time, that the ADA and the CDC are vigilant and are keeping up with additional science as it comes in so that they can modify these recommendations. And we can go back to a point where we are practicing safely and following guidelines that are scientifically supported rather than what makes sense and what feels good or what is, what I think, in my opinion, is better than the other things. We need to have really science-proven things that help us reduce the transmission from our patients to ourselves, and of course from our staff and between patients. We're all in this together, and we're all trying to be as safe as possible. Anyway, guys, this is way too long here, so I'm going to cut this at this point. I hope that you guys are now back to work and are doing well. I'm going to do another video, and we're going to talk about this subject matter more, as much as everybody else has had, like COVID-19. It's just overwhelmed by too much information. Nobody wants to hear about it. We'll get back to regular endo cases as well soon. Alrighty, guys. Thank you so much for watching this video, and if you like it, put a little bit of a comment below and let me know how this is practicing, how it's affecting your practice. What are you doing that's different than what the CDC is saying here? Practice with common sense, you know, hand hygiene and the stuff that you were doing before, but really to the universal precautions to the T. Shields, masks are important. Controlling the aerosol to the extent possible is important, and the rest of it is just common sense. Alrighty, guys, thank you so much. I'll see you guys soon.